All right, good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center, and welcome to today's program. I've got just a few intro slides. So as you joined us today, some webinar tips and notes. The phone or your microphone were muted when you joined us. Please go ahead and use the Q&A for the chat function. If you have any questions to our presenters today, please use that chat function for the Q&As. There is a post-webinar evaluation that will populate beneath the session when we're done. And CME credit is only available during the live presentation. And if you haven't done our CME information with the cloud CME, there'll be information in my thank you email to everybody that joined us. This is being recorded and will be available on our website later, along with the presentation slides. And let's see, so this is our standard disclaimer. Opinions expressed in the presentation on the following slides are solely those of the presenters and not necessarily those of the organization sponsoring the webinar, and the organizations do not guarantee accuracy or reliability of the information provided herein. All right, again, check our website for upcoming webinars and events. Again, this information will be, you don't have to worry about copying that URL down right now. I'll have that in my thank you email. Your opinion is valuable to us. This is what brings us exciting topics. So please go ahead and do that evaluation, and you have a chance to let us know what else you'd like to hear about. We can find the speakers for that. So without any further ado, we've got Managing Valley Fever for Arizonans. It all starts with awareness. We've got Dr. John Galgiani, who is the director of the Valley Fever Center of Excellence here at the University of Arizona. We've got Dr. Robert Johns. He's the division medical director for the Banner Urgent Care. We also have a community member who's going to be sharing his personal story. And without any further ado, we're going to go ahead and stop here, and Dr. Galgiani will go ahead and start. If you want to pull up your file, sir.
Hi there. Yeah, I'm John Galgiani, and let me see if I can figure out how to share my screen. All right.
And it's populating, just a second.
All right, let me see if I can.
Presentation mode next.
Yeah, I'm trying to, I guess I can, I'm trying to get, can you see my screen?
I can see your screen, but it's not in presentation mode. It's just the PowerPoint.
Okay. Yeah, let me have to get something off here. Sorry for the delay.
That's all right.
All right. There's things in the way of me getting to, here it is.
Is the presentation mode that little TV on a little stand at the top of the gray?
That better?
There we go. Perfect. All right, Dr. Galgiani, take it away.
Sorry. Yeah. So I'm John Galgiani, and as you heard, Dr. Robert Johns is with us, and Jim is going to be very kindly lending some of his time. He was one of my patients, and he has got some interesting things to say about his experience, which fit right in with this conversation. So we're going to talk about managing valley fever for Arizonas, and the emphasis here is that it all starts with awareness. And I'm going to really put most of my emphasis on that. We're going to then go lightly on the rest of it, but in fact, that information can be obtained, and I'll point to you where you can get that. But nothing happens until you think about this disease. Let's see. There we go. So we have no conflicts unless somebody's changed their mind about that. And this is, in fact, part of this entire week we're proclaiming, as did the governor, the 23rd Annual Valley Fever Awareness Week. We collect both ends of the week, so it's more than 7 days. It's both weekends. And we limit it to 1 week because there are actually activities that spill over to the beginning and after the week. And we figured that if we actually made it a month of awareness, it would spill over to the entire year. So we limit it to 1 week, and that's right now. And so just so we're all talking about the same disease, hopefully some of this information will be very familiar to you. but I just sort of orient you to coccidioidomycosis, which is a name nobody likes to say, so it's nicknamed cocci or valley fever. It is caused by a fungus, and that's the genus is Coccidioides. We think that if you inhale a single spore, it only takes one spore actually to cause an infection. So this is really a professional pathogen. And we used to say maybe there's 150,000 infections per year, but just this year, better estimates have been produced by the CDC, which now projects there's maybe 500,000 infections per year. That rests on some assumptions because many of those cases are not reported. It's a very underreported disease. That's actually part of what we're going to be discussing today. But that's currently the number they're throwing around in terms of all infections. The estimates are that with global warming and changes in our climate, that the endemic regions, which I'll show you some maps of approximately where it is now, could actually extend to the Canadian border by the end of the century. That's the prediction based on rainfall and temperature estimates. The ecology may be more complicated than that, but time will tell. So some patients, it's pretty clear, myself included, I know I had valley fever because I was doing skin testing surveillance because our laboratory works with the infection, and I converted my skin test, but had no symptoms whatsoever. So some people can be infected and have no illness whatsoever. Other patients, though, get a self-limited disease, and sometimes it's been referred to in textbooks as a flu-like illness, but I think that really is misleading. People who get sick with this disease are often amazed at how sick they are for how long they are. Yes, it is generally self-limited, but it's often very impacting on patients for a long period of time. And then a small percentage of people go on to have chronic infections where the fungus continues to proliferate and causes disease outside of the chest, in skin, bone, or even meningitis is the most common forms, but really it can be almost anywhere in the body. Those are the main ones. And a small percentage of people also actually can have fatal infections. In fact, meningitis, if it's untreated, is uniformly fatal within 2 years. Just in terms of overall impact, a couple of economic impact studies have been done, one in California and one in Arizona by the Seidman Institute, and the two combined is about $1.5 billion economic impact to California and Arizona combined each year. This is also worse for certain groups. The older people over 65, for example, have worse disease, people of color, and women that are pregnant, especially in the third trimester. If you get a new diagnosis of cocci during pregnancy, it elevates it to a high-risk situation. And finally, and probably the most clearly difficult situation are people who have severe immunosuppression, like AIDS or organ transplants. Also, patients who are on biologic response modifiers or more selective immunosuppression, that's a complicated area, but they also can have more problems. And actually, if you run those numbers, the impact of this disease is similar to polio, chickenpox, or measles before there were vaccines against those diseases. And one thing about this disease is after infection, after you get over it, and perhaps even those people who get the more complicated forms, they develop systemic immunity for the rest of their life. And that suggests that maybe we could solve this problem with a vaccine. In fact, the University of Arizona has discovered a vaccine which is in development by Anavive Life Sciences as a vaccine for dogs, and that hopefully will be in veterinary offices within a year. They also have funding to move this vaccine forward, actually towards using in humans as well. So I'm very excited about that possibility, but we're not going to really be talking about that today. So this is where I live in looking up at the front range of the Catalina Mountains. And over here, I show the spores. This is a scanning EM of the mycelial form of the fungus. That's what would be found on a petri dish and probably what's out in the desert. And if you inhale one of those spores, that little white thing, then they break off into single spores like that. And if you inhale one of those, you develop a pneumonia, like right here. This could be anything. In fact, it could be Klebsiella, it could be staph, could be pneumococcal, but in fact, this is an X-ray of somebody with coccidioidal pneumonia. And then if you looked at that microscopically, you see these enormous cells. These are neutrophils and other leukocytes, and this is 50, 70 microns in diameter. And each one of these little spots inside this spherule is a new progeny, an endospore. And so when one of these ruptures, and its life cycle is about 4 days, you spill out literally 2 log amplification, maybe 100 spores each cycle. So you go from 1 spore to 100 to 10,000, and pretty soon you're into some real numbers. So I mentioned maps, and in fact, between us, California and Arizona, almost all the cases that are reported to the CDC occur. And it turns out because of where the endemic population is in Arizona, especially in Maricopa County, that 2/3 of all US valley fever infections come from our state. The other third, most of the other third comes from California. But people travel, and actually you can visit California and Arizona, also St. George and southeastern New Mexico, West Texas has disease, but the big areas are California and Arizona. And these gray squares are people have returned home from visiting Arizona or Central California and get diagnosed outside of the endemic regions. And I think Arizona probably takes the lion's share of tourists too, as well as the endemic disease. Let me just also say that this is a CDC map of the overall endemic region of cocci, and they've fuzzied it out because there's actually now a little spot in southeastern Washington, and we've known for a while up in the Dinosaur National Monument, and also I've mentioned the other areas here. So they tried to be intentional that there may be small foci elsewhere in the West that we don't know about yet. So this is personal for us at the University of Arizona. These are a couple of people. One's Lauren Woods, who I remember, in fact, was involved with his care many years ago. He was our star basketball center who had to drop out from his junior NCAA tournament because of 2 collapsed vertebrae due to cocci in his spine. He actually did fine. He got back and went on to the NBA and had a nice career there and in Europe. And then on the other side is a picture of Sterling Lewis, who is a classmate and a teammate of Rob Gronkowski. He went after graduating from the U of A back to Texas, and then more recently came down with valley fever, and he died of that disease. So these are just examples of athletes that have had this disease. And actually this fall, we've been using athletes as a point of contact to get people interested in this disease. Michael Bates was another football player here. He also was a medalist in the Summer Olympics, winning the bronze medal in year 2000 in the 200 meter in Spain, and trying to get people's attention about people knowing about valley fever. And as I said, it's all about awareness. And I've really come to realize nothing happens if you don't think about this disease. And so this year, especially, we really focused on this concept of knowing about it. And with awareness, you get earlier diagnoses. And we're going to talk about the need for that and the value of that. And then once you have a specific diagnosis, then you get precise care. And we're doing that in affiliation and in collaboration with Banner. And Dr. Johns is going to give some comments about how that's working in Banner Urgent Care in just a moment. But also, if you know about this disease, you start thinking about what could be done better. As you may know, if you want to diagnose this disease, it usually involves a blood test, which is a send out. You don't get those results back for days in most cases, but can be weeks. And then it'd be nice to have a point of care test. We're helping to work on that. Better drugs would be good because none of the treatments we have cure this disease. In fact, if you get valley fever meningitis, the recommendation is never to stop treatment ever, no matter how well you recover, because the drugs don't cure this disease. And I mentioned vaccines, and support for moving this forward is all part of awareness. So I think that's what I'm going to spend most of my time talking about for the rest of this webinar, and then leave hopefully plenty of time for questions and other comments. So I mentioned it all starts with awareness. And this is a quote from a paper published 15 years ago from a really nice study that was done by Arizona Department of Health Services, where they called back every 10th patient reported to have cocci and asked them a lot of questions. And almost everybody that was contacted was happy to answer our 1-year survey, which tells you how interested they were in getting the word out once they themselves had experienced this disease. So the quote is, persons who knew about coccidioidomycosis before seeking healthcare were more likely to request coccidioidomycosis testing and were more likely to receive a diagnosis earlier than those who were not familiar with the disease. And it was because they asked their doctors, don't you think you should test me for it? So patient awareness helps getting earlier diagnosis every much as having the medical profession be aware of this. And in fact, that's part of what keeps, I think, Department of Health interested in this disease. It's the most commonly reported disease to the state of Arizona, other than sexually transmitted diseases. But even so, it's not transmissible. So I think this idea of knowing about the disease and getting information about is really, and that earlier diagnosis comes from that, is part of why Arizona Department of Health and the county health departments are very interested in this. So it also starts with awareness in the clinics. And here the story is a little more complicated. And I've shown here publications from medical clinics, from EDs, and from urgent cares. This, in fact, is a publication from Banner at different years. And you can see in a couple of clinics, the range of patients with pneumonia being tested, CAP or community-acquired pneumonia, being tested for valley fever ranged from 2 to 13%. In EDs, it was as low as 2.8%. And in urgent cares back in 2019, it was 2%. A similar state, so that's all Arizona data. But Kaiser, Southern California Kaiser published a paper also showing a similar kind of number in its endemic regions for valley fever in California. So I think it's quite widespread in the endemic regions that amazingly, and I'm not talking about where it's not common, I'm talking about where the disease is very common. It's poorly thought of and diagnostics being done for it. And there are consequences of that inaction. The obvious one is these people will often be treated as if it's a bacterial process, sometimes multiple times with antibacterial drugs. And that's just not going to help somebody with a fungal infection. And then also, there's if you have a patient, as I said, for weeks to months with an illness, you're going to keep doing things, diagnostic tests, even invasive procedures. And they may even get hospitalized because they didn't know what was going on. And then a blood test might be done to make the diagnosis, something that could have been done without that hospitalization. And finally, recently, the CDC just published an estimate looking at insurance records as to the cost of care for patients in days with symptoms prior to the time of getting diagnosed. And from that analysis, they came up with the overall statistic of each day of delay from onset of illness to the actual diagnostic test being performed was $175 per day. So there's real costs involved with this, as well as patient uncertainty and medical utilization that is just going nowhere. So we have with us James, and here I'd love it if you would just go through some of the experience you went through. Do you have time with that?
Sure. Well, I started getting sick at the end of February, 1st of March, and I had neck and body aches, fever, headaches, night sweats, fatigue, and then a skin rash, which was, I thought I had the flu and was just going to let it run its course. Then on March 15th, I developed itchy blister bumps all over, but mostly on my hands. I went to the walk-in clinic because I was afraid I may have shingles. They didn't do any type of test, but said I had a staph infection. They prescribed antibiotics, and it seemed to get better. All my symptoms stopped around March 20th, but then my fever and my night sweats returned just a couple days for a couple days at the end of March. Then on April 1st, I saw my primary care physician and some basic blood work was done. And he ordered a chest x-ray. He said we needed to rule out emphysema and valley fever. This is the first time I've ever heard of valley fever. Then on April 4th, the doctor office called and said the x-ray showed I had pneumonia. So I was prescribed another round of antibiotics for 10 days. And on May 13th, I had another appointment with my doctor. I was feeling pretty good, except I was still feeling fatigued. And my doctor ordered a breathing test along with lung and heart scans. Returned to my doctor on June the 4th and was told I had a breathing test. And in May, it showed I had COPD. So he prescribed Breztri for that. I had a heart scan on June 14th. The doctor's office called and said the scan showed a large mass in my lung. So they wanted to change my lung scan to a scan with contrast, which was done on June 26th. On July 8th, my doctor went over the scan results with me and assumed I had cancer and referred me to a pulmonologist. I did ask if they tested for valley fever, and he said the test was never done. My appointment with pulmonologist was on July 11th. And after listening to everything from March 1st, she said she believed I had valley fever. So I had blood work done and tested positive. She prescribed the fluconazole, which I took for 6 weeks, which seemed to shrink the mass somewhat, which ruled out cancer. If a valley fever test would have been done in March, I could have been on the road to recovery a lot sooner.
James, thank you really for going through that. And I can just tell you, I'm going to let Dr. Johns comment on that in a moment as well. But that your story, unfortunately, is not uncommon. And I think you can see the value that I'm trying to get across here is thinking about a very common disease like valley fever, and I'll show you some of the numbers in just a moment, is worth doing where this disease is common. And over, I wouldn't worry about over testing for valley fever. I think the problem now is under testing.
Exactly.
Yeah, thank you very much, James.
Well, you're quite welcome.
You're more than welcome to if you have things you have to get done. We're happy to have you stay with us, but happy to let you go too.
Okay, thank you very much.
So it isn't like we haven't had presentations like the one we're doing today about this problem before, about people ought to test for valley fever. But in fact, that just hasn't worked really well, as judged by the fact that things haven't really improved much. And I can tell you another attempt at that sort of approach has been at the Mayo Clinic. A friend of mine, Janice Blair, has been trying to get the emergency room to improve. And after talking to them intensely for a while, they got some improvement. But then 6 months later or 9 months later, they found that they relapsed back to not testing pneumonia for valley fever in the emergency room. And so we in Banner have tried to take a systems approach, and it really started literally 10 years ago because the University of Arizona physician groups, both here in Tucson and in the College of Medicine in Phoenix, then affiliated with Banner Health, and they actually celebrated that. The Board of Regents had a celebration of that just earlier this month. And then in 2018, Banner Corp has a program for trying to define best practices. And they call these clinical practices, and stakeholder groups get together and define what everyone agrees is the best practice. And then that is then implemented within the Banner Health system. And I took that in place quality improvement structure and used it to create a valley fever evaluation and management clinical practice for the ambulatory care space. And I already pointed to the data that we identified from chart review that beta urgent care was not testing people for pneumonia very often. So we focused on urgent care as our approach. And what we did was simple things. We have every quarterly, there is a review and update for the clinicians in urgent care. And then onboarding, there's a set of things that are gone through. A single slide was put in place for that, and nothing more than that. But then that was done in 2020. And then in 2023, I was able to get support from Banner Data Analytics to create dashboards, a dashboard specifically for the urgent care. So I could then feed back exactly what was going on within Banner Care with respect to their own practices in testing for valley fever. And I'm going to show you some of that data. Here's the single slide that was used on those quarterly reports. And it shows nothing more. And the original thing was keep it simple. So we focus on nothing but patients with pneumonia. Even though we'll talk about, and I think James showed, there are other symptoms that valley fever certainly cause. But we just talked about if you have a patient with pneumonia, you should test them for valley fever. And here's from that dashboard I mentioned that we now have up, and it is really almost in real-time data. Actually, it has about a 36-hour lag time from last updating. And what I'm showing you here is in red is the numbers of people with pneumonia that are tested for valley fever per thousand tests, diagnoses. That is ICD-10 codes for J18, which is the code for pneumonia organism unspecified, which is basically the ICD-10 for community-acquired pneumonia. And you can see that went from under 2% in 2018 on up, and in this year to date, it's up to 43%. That is 427 per thousand, or a testing rate now of 43% of pneumonia patients being tested for cocci in 2025. And in fact, I just have to show you that this year by quarter, it's even going up further. And this is continuing to hold. And I'm very excited about that. The other thing, which is kind of interesting, the more we test, you see that these numbers are coming down. It's now meaning out, and it's around 12%. I'll show you some data about that in just a moment. But this is now giving us the actual estimate of how much pneumonia year in and year out is due to valley fever in our endemic region. Another thing that's really interesting that has not been known before we did this work in urgent care is that erythema nodosum, which is known obviously to be that valley fever is a cause of enodosum, but enodosum is caused by dozens of things. It's not a specific rash. It's very, very striking. People need help with it because it hurts and people don't like it, but many things can cause it. But it turns out that in Arizona, if you get erythema nodosum, this is the data from urgent care, you can see that on average, it's over 60% due to valley fever. And the testing for enodosum, as we recognize that, has also gone up now up to 78% of patients with enodosum being tested. And this data did not exist. We always knew that enodosum was a valley fever caused enodosum, but that in the endemic region, it was this high is news that came from our work with urgent care. Now, this is a slide going from 2021 all the way up to the beginning of 2025. And I show you two curves here. This is 30-day moving averages in black of patients tested for valley fever that have, that is patients with pneumonia or with erythema nodosum. Most of these are pneumonia patients that are tested for valley fever, and the percent of those tests that are positive in black. And you can see that sometimes it's very high, at other times it's very close to zero. So it goes up and down, but on average, in the black horizontal line shows this is the average year in and year out. It's about 12% of all pneumonias all year long is valley fever. Interestingly, in red here, I'm showing you all the other people who in urgent care did not have either ICD-10 codes for pneumonia or for erythema nodosum, but did have a test for valley fever. And we don't quite know what the clinician's reason for testing. We know it wasn't because they already knew they had valley fever, because the query that we have for this dashboard eliminates prior cases. But you can see that actually on average, it's about 10%. It's only 2% different than the people we're recommending should be tested for valley fever. We don't know why these people are being tested, but I'll show you a glimpse to that in just a moment. Now, as James's symptoms shows you, that the other syndromes can be triggered by valley fever. You can have respiratory complaints that may not actually make the clinician think it's pneumonia. We'll talk about that in just a second. But also aches and pains, and a synonym for valley fever is desert rheumatism, because myalgias, arthralgias, headache is very common. Fortunately, most of these people don't have meningitis, but it's very common as part of the syndrome. The rashes I mentioned, erythema nodosum, but there are other rashes, harder to define, that come with this. And then the fatigue, which James had, is also very striking in many patients, and it often is the last symptom to go away and may last for many weeks. So there are lots of different things that can make you think of valley fever, but these are not very specific recommendations. When I went back and looked at people in urgent care that were tested for valley fever but did not have pneumonia or erythema nodosum, this was for the 2 years, 2023 and 2024. These are the number of patients that had these various ICD-10 codes. And you can see that most of them with the highest numbers of ICD-10 codes were respiratory sorts of things. There was rashes, fatigue. A few thought they already had a diagnosis, and that's why they were testing. But a lot, at least in Banner Urgent Care, a lot of them had a syndrome that wasn't really strictly called pneumonia, but were respiratory symptoms in nature. So with that in mind, a focus group in Banner Urgent Care has been getting together for the last several months to revise what is being recommended within Banner Urgent Care. And what has come up with is now this single card to replace the one I showed you before, that in addition to pneumonia, suspected pneumonia, and erythema nodosum is now on that. And also, you can see the wording here may still order the serologies, even the patient isn't in clinic, or if you're sending the patient for an X-ray, for example, or to get the test. So it's a little more relaxed. And I'll ask Dr. Johns to comment on this, but it's to allow, if you suspect that if you suspect that the patient needs an X-ray, whether or not it ends up being pneumonia or not, that might be a cue that the patient might be sick enough that a valley fever test might be useful. Robert, do you want to make some comments about any of this and how you watch this unfold? It's been wonderful working with you.
Sure. So I'm Dr. Rob Johns, as Dr. Galgiani says. As you showed you back in 2020, the urgent care was not doing much testing of cocci. And we really started putting a push to it. It was a slow grind at first. And then I think as providers started seeing more and more positives come back with their pneumonias, it has helped to push the movement along. And that's how we're able to support the 50% right now at testing. I mean, I'd like to get higher. And we do a lot to try to impress upon our providers to test. And as we were saying, for the last several years, it's been anybody with an infiltrate, they needed to have the valley fever test. And now it's gotten to the point that if we're thinking the patient needs a chest X-ray, we're just advising go ahead and get the valley fever test, because there are so many positives even without an infiltrate. And as far as the erythema nodosum goes, I started testing for that a few years back, and I'm batting probably a 90% average on positive cocci with my erythema nodosum. And the other thing I started finding was patients that had had been having a cough and then all of a sudden develop a non-specific rash, that those people were testing positive for valley fever. And so, and this is more just like a macular rash. It wasn't erythema nodosum or anything, but I just found that the rash and the cough together was typically a sign that it's going to be valley fever. And we do have a few clinics up in Colorado, and we are advising them that if they are interviewing a patient and find out that they have been in the endemic area in the past 30 days, that they should follow our rules and have those people tested, because I've heard horror stories of people going back to Minnesota and other places that ended up having surgery done because the doctor was convinced it was cancer, and then the pathologist tells them no, it was valley fever. I'm glad that Dr. Galgiani is trying to work with the ERs at this point in time, because about a year ago, we saw actually two cases fairly close together where a patient was seen at an ER and put on antibiotics for their pneumonia, and then came into the urgent care because they weren't getting better. I remember one, his oxygen was probably in the mid 80s. And when we did the chest x-ray, he now had diffuse disease bilaterally. He ended up in the hospital with a pneumonectomy and probably about a 4-week stay in the hospital, just because this was not picked up sooner. It's pretty impressive when you see those x-rays and then you review the chart of somebody and think that this could have all been prevented. As a native Arizonan, I've always been aware of the disease. And I think one of the biggest problems we have, as Dr. Galgiani says, is the recognition and the testing of it. Is that so many people, docs have relocated to Arizona and just don't know anything about the disease. And so if it's not on your mind, you don't test for it. And I think he is correct where he just needs to be tested all the time. I have one of my friends, her brother can't play his guitar anymore because it took him 6 months to diagnose valley fever, and the arthritis is so bad in his hands now that he can't play. And so we continue to push the testing in the urgent care. And like I say, initially I was probably sending emails out monthly. In fact, we've gotten better. I've slacked off a little bit, but we do reporting at our meetings and try to relay the changes that we have. And we are, as we get better at it, we are going to add more and more things, reasons to test for it. And that's been our path in the urgent care. It's just awareness, awareness, and awareness.
Thank you very much. Robert, that's very helpful. And I think it's worth hearing. And I think probably you probably would agree that early on, not everybody of your cadre thought this testing business was a great thing to do, but that there's been a change in the sense about that. Would you agree with that, James? Robert?
Yes, it took a little while, and I was even a little slow at it at first, and then it's like the more I tested, the more positives I got, and the more positives I got, the more I wanted to test.
Yeah, there's a whole literature on why it's hard to get doctors to change. They have to unlearn they're finished products now. They know what they're doing, and so to relearn is you got to get past that something needs to change. So that's really what I had to kind of emphasize, is that change is possible and it's really valuable. And this is, so you have to consider the diagnosis. And then once you do that, you have to do the right tests, check for risk factors, check for complications, and initiate management. I'm going to gloss over the rest of this here very in short shrift, but it's all of this is available in a little booklet, which is online on our Valley Fever Center website, vfce.arizona.edu. We actually have it in hard copy. Anyone that likes that, to put, it's a form factor that it can fit in a lab coat pocket. And it's very short, and it's the front end of early diagnosis of valley fever. And we go over this acronym of COXI. So after you make a diagnosis, you have to check for risk factors and think about the pulmonary complications, which are primarily in patients who have diabetes or people who have underlying cardiopulmonary disease. The data is very clear for diabetics. I think for other cardiopulmonary disease, it just makes sense that any infection of the lungs is going to be bad in those patients. And then for disseminated disease, I already mentioned the most critical ones, immunodeficiency and pregnancy, but also much less impacting, probably real, but less impacting, is men are more likely to disseminate than females, racial background, African Americans and Filipinos especially, and adults probably get more disseminated disease than kids. And then often the complications are already evident early on. The complications tend to be part of the front end of the disease, and they tend to be something that patients point to. That is, they are caused by acute inflammation. So you get swelling or redness. I'll show you some pictures of that. And typically a review of systems and a quick physical exam will disclose people that are really starting to have disseminated disease. And if you do have focal findings, that warrants more evaluation and gets to be each individual patients because of their own sort of situation. Here are some examples. These are chronic. This is obviously a complex cavity. Here's a thin wall cavity in people with fibrocavitary COXI. Here's the back of a fellow with paravertebral abscesses due to COXI. All these fistula from someone with multiple cutaneous lesions. This is the elbow, another cutaneous lesion. It'd be hard to know what that is without a biopsy. Similarly, another coccidioidal skin lesion. I think that's overlying an osteo on the foot. This is a synovial cyst that grew COXI, and again, an osteo in a little kid. So you can see these things are usually not subtle. They might be ignored if you're not thinking maybe that's disseminated COXI, but they should actually be evaluated. So as I say, that's the acronym that I like, COCCI. And if you order a test and it's negative and the patient's still sick, retesting is often useful because false positives we take as typically real positive. It's case definition for the state if you have a positive serology. And most of them are usual. If you're doing it for an illness, it's almost always a true positive, but false negatives are very common with this. So retesting later often will give you a second shot on goal and give you a diagnosis. And then if you have risk factors, if you have complications evident, that's when maybe it's not a primary care problem and maybe to get specialty care for that. And then you initiate therapy. And that is something that we could spend another hour on, which I'm not going to, but basically talk with the patient to make sure things resolve. Patients often lose weight early in the course of their illness and it stabilizes, and then they get disappointed because it all comes back. Look for new signs and symptoms over the next several months. Repeat testing is recommended, although frankly, if the patient's getting better, the antibody testing probably, I've gotten less and less worried whether it is behaving or not, that patients improving are patients improving from clinical standpoint. And finally, a repeat chest x-ray is useful even in patients that are improving because some develop spots on the lung. And if you know that's there because of a COXI pneumonia that's resolved to a nodule, it may save them a biopsy years later if it's found as an asymptomatic finding. And then we're not going to talk about therapy either, but in fact, most patients get better on their own. And whether or not to start treatment is a case-by-case basis. There's no randomized trial to tell you that you have to do that, and it may help, may not. And the recommendation is to finish within 6 months. 3 to 6 months is the standard recommendation, at least by the Infectious Disease Society of America, if you do decide to start treatment. So all of that information that I've just flitted through is in this little booklet. And I recommend that. And we could take questions about this if we have time. I think we're doing pretty good, which is what I hope to do. So, but it all comes back to awareness. And so I think the point of this presentation is to go ahead and be testing patients that you're not quite sure where things are going, or if they have a clear-cut pneumonia or a rash, all these kinds of things Dr. Johns emphasized to other syndromes like I did. It's perfectly reasonable to be getting cocci-serologies in those. We have an interest in trying to understand who to recommend testing for better, and maybe with machine learning of natural language, the notes themselves, rather than just the ICD-10 codes, we'll be able to get some better sense of who we should recommend testing for. But it's a common disease, and that's kind of where I want you to be. Is hope you start testing people more in your practice from this point on. I'm going to stop at that point. Melanie, do you have an eye on whether there's questions coming in?
Yes, we do. We do have a few questions that have come into the chat. The first one, I'm
why
going
don't you go ahead and read ones that you think sound wonderfully interesting.
well, we've got a few of them, so I'm going to scroll back here to the first one. It's to Dr. Johns. How do you go about educating your providers to start testing or changing current clinician practice? Influencing clinicians to change their practice in a sustainable manner can be difficult.
A lot of it is explaining the why.
Okay.
Got to explain the why behind why you're doing it. And now that we're pulling up more and more data from the urgent care, Dr. Galgiani has been able to publish the prevalence of it, which helps to hopefully change practice habits. But it was a lot of constant reminding. And then also, like I said, I liked sending out copies of x-rays of what the pneumonia first looked like and what it looked like 3 weeks later, and relaying hospital course with my providers. And so basically, though, it was a lot of just reminding and reminding.
Yeah, I can't agree with you more. Let me just also add, I think repetition is absolutely critical. And I've also been feeding back, and I think being able to give back to the urgent care clinician their own data and showing them the changes that are going on in their practice makes it, this is, you have a busy clinic, right, Robert? And, once in a while it's valley fever. So this is competing with everything else that's going on during the day. But to start seeing it over and over again, it starts to become a spinal reflex. And so you got pneumonia, we're going to test you for valley fever without even thinking of it. It's not like, should I? It's what we do. And
I think also it did help where we just basically made it an expectation, not an option, but an expectation. Anybody with an infiltrate was going to get a cocci test.
All right. A follow-up to that is, how do you manage the follow-up in urgent care? If there was a long wait for specialists, or a patient had no PCP or uninsured, do you sometimes start antifungals in urgent care?
Luckily, with Dr. Galgiani's help, we have some valley fever clinics that we're able to refer to if they don't have a PCP. And as it says, I think in Dr. Galgiani's handout that he's produced, most people don't need to be treated. And so you don't necessarily have to get them in like in the next day or two. We've got a week or whatever to get them in. And so that helps.
Okay.
Yeah, and what we've tried to do, so fortunately I have a valley fever clinic in downtown Phoenix, as well as two valley fever clinics here in Tucson at Banner North. And we have as our objective to take patients on referral within 5 working days from urgent care referrals. So it's not, that's been a challenge in Phoenix recently, but I think we're going to get back. We lost some staff, which I think is getting repopulated. But I think that's the key, that if you can get a visit, and I'm pretty comfortable, the patients who look like they can't wait 5 days, they should go to the emergency. But this is a subacute problem, and often they've been sick for weeks when the diagnosis gets made, even the ones that you test on your first visit. And so waiting 5 days probably not going to change the course of events or the overall outcome of the illness. But that's different than having a 2-month wait, and I would hate to have that happen. So we're trying to address that. That's an important issue.
All right. The next, I have a 3-part question. So I'll start with the first one. Was it mentioned that our bodies do build a natural immunity once treated?
Yes. It's of those, we have an annual meeting of people that are interested in valley fever since 1956. And when we go to those meetings, I can't remember anyone showing a patient who clearly had diagnosed cocci, lobar pneumonia, and then years later got a second lobar pneumonia, like they got a second inhaled spore. We think that it's lifelong immunity from that first infection. You can have reactivation. We think that the fungus probably in most people does not leave your body after the first infection. So there are examples of 15 years later in Spain, a patient who comes down with AIDS who left the Southwest getting a diagnosis of valley fever in Spain, which he took with him from an infection that was at least 15 years old, but not from a second exposure. And I think that's and I actually think, for reasons I could unpack, but we won't take the time to do, it looks like people who get disseminated disease probably actually get systemic immunity anyway. It's only those lesions that they develop that are just not susceptible to that systemic immunity, that you don't see new sites developing over time. It's the ones that come out early on in the course of the illness.
All right, the next part of this question, what are the long-term effects of being on antifungals for the kidneys, the lungs, or reproductive systems? And do these medicines lower the body's natural immune system?
We don't think so.
Okay.
And we're thinking mostly about fluconazole. I'm not going to address amphotericin. That's a difficult situation. But fluconazole, which is the most commonly used azole treatment for valley fever, it's been around since the late 1980s. And we've had kids who developed meningitis who are now adults who have not stopped taking fluconazole since then. There's talk about hepatitis, but frankly, it's way exaggerated. The number, I've never had a patient who I clearly had biopsy-proven hepatitis from fluconazole, and it doesn't, it leaves the body. It doesn't accumulate in the body. We don't know of any long-term effects. So it's useful. Now there's side effects. Some people hate the drug. It causes chapped lips. You can have hair thinning, rashes because dry skin gets irritated, and some people hate the taste. It can be GI symptoms. So a lot of things that people don't often like with fluconazole, but it's not actually life-threatening toxicities. And I think the immune system probably goes on fine even if you're on fluconazole.
So part of the next question talks about that. During personal research, posaconazole is not a medicine that is typically suggested, although it is an antifungal medicine. What reason or reasons are fluconazole, itraconazole, or amphotericin B prescribed before posaconazole?
Sure. Let me make a couple of comments, and Robert, if you have any further thoughts, happy to hear yours too. So fluconazole is very well absorbed. It's the least expensive, so it has predictable levels, and it's cheapest. The others have, all the drugs you just mentioned have activity against valley fever and are used, but their levels they have other pros and cons. The levels are not as reliable. There are drug interactions, some other toxicities, but may in some cases be preferable. So we do use them, but usually as second-line treatment. Amphotericin is a special case, and it's very toxic, and it is used in very selected patients where they're trying to pull out all the stops to do everything possible. Do you have any thoughts about that, Robert?
I agree. I just agree with you. Amphotericin B, we always call that awfultericin B, just because of all the side effects of it.
Gotcha. All right. And last question, seems incredible to this person, as long as we've had valley fever, especially here in Arizona, that not all doctors would catch this. You touched on it somewhat. Do you think it can be related to the influx of doctors that just are not familiar with the disease?
Yes. It's very simple. I think that, like I say, I was born and raised here, and valley fever has always been, talked about, but you get people coming from Boston or wherever, and they just don't know about it. It's just like, if I went back east, I'd be afraid I'm going to miss Lyme's disease because I
Sure.
just don't deal with it all the time. And it's been a hard lift, getting, providers trained into recognizing that there are diseases in this area that are just endemic to this area. And, I don't know if it would take something like from the health department to kind of just start, every time a new doctor gets a license in this area, to send stuff out to them about it, just so they're aware of it from the start. But that is the big problem. And it's, if you don't think about it, you're never going to diagnose it.
Yeah,
And
I would add to that, Robert, that I think patients expecting to be tested, I think direct advertising to patients for this disease is my idea of how it's really going to happen. I think I would love the Office of Tourism, Arizona Office of Tourism, to start putting information about drink water when you're on the desert, know about not putting your hands down holes. And by the way, there's this disease called valley fever you should know about, and here are the symptoms. That would be useful. And and certainly public health is putting things out on their website, and they like to talk about this. But frankly, what I said in my op-ed, Arizona Republic, last in September, this information about valley fever should be in sports stadiums, not just in doctors' offices. I think it should be just in conversation. You mentioned Lyme disease. Everybody talks about Lyme disease back east. We should be just doing that. The more you know about this disease, the less scary it gets. And I think there are economic benefits to having the information out there, rather than pretending it doesn't exist. So I'm on a jag here to get it really in the public eye, as really good public health, and probably good for the economy too.
well, and we are a transient state. We have a lot of people that come here for the beautiful weather, especially that we're experiencing now, and they're going back east. So interesting.
I do try to tell some of our winter visitors, if you go home and you start developing some weird symptoms that your doctor doesn't know about, once you get back to Minnesota or wherever it is, make sure you tell them you've been to Arizona and to test you for cocci.
Yeah.
And Lyme disease down here. Do docs test for Lyme disease down here like it is? I'm originally from back east. I know about Lyme disease, but we
Probably
don't
know more than
necessarily have
me.
the ticks here that they do back there.
There's never been a reported case of Lyme disease in Arizona. And finally, there's a director's message on our Valley Fever Center for Excellence that actually goes into this in more detail if anyone wants, if they didn't get enough on this hour.
So I will include that URL. I put it in the chat a little bit earlier, and I'll put that in my thank you email to everybody that has joined us today. And we are right at 1 o'clock. Dr. Galgiani and Dr. Johns, thank you so much for joining us and sharing this very important information, especially for our state, our Arizona, and letting people be aware that it's really common, but it just hasn't been getting tested. So that awareness is very important for everybody. All right, so thank you again for joining us, and hope everybody has a great rest of their afternoon, and we will see you again. Thanks, everyone.
Thank you. Bye-bye.
Bye-bye. Thank you.